also like to thank Dr. Manoj and Dr. Uni for having me here, and also thank my previous speakers, because most of the things which I'm going to talk about are kind of covered, and I'll just try and sum it in my talk. So why do we need the biomarkers is what I would like to start with. So as I was going through various reports, I realized that it's a meager 40% of patients who receive significant improvement in BCVA after 1 year of treatment with anti-VEGF. And DRCR net reported that almost 2/3 of the patients who have received anti-VEGF for almost a year may still have persistent edema and can have reduced visual acuity. So are we justified in treating all our DME patients with monthly anti-VEGF injection is the basis of the discussion that we are going to have. So should we instead not try and tailor-made our approach towards each patient to minimize the recurrences and minimize the number of invasive procedures that we do? So I split my talk into two. That are there some biomarkers which tell us whether steroids can be used as a primary line of action, and are there some biomarkers which can tell us that this is the time to switch? So going to the first one, either steroid or anti-VEGF, we had some discussion on this earlier. So we do know that in pseudophakic eyes, in patients who have cardiovascular history of disease, post-vitrectomy patients, and people who are reluctant to have too many injections, this may be useful, but there aren't any huge RCTs which I have compared directly as to which one is better. Most of the data is from post hoc analysis of large studies which have been done. Few non-imaging biomarkers are there. These are the few imaging biomarkers that I did come across. I'll just run through each one of them one by one. First is obviously what we all see all the time, the CRT. But this has not been shown to be relevant or predictive of final BCVA, because paradoxically some patients with large CRT may have very poor vision and vice versa. But then definitely, statistically, it makes them look good, because larger the CRT, more will be your proportionate decrease, and they will improve your statistical results. Also, the flip side, to look at the fairer side to it, that if you have a larger CRT to begin with, you may think of DEXA to start with, or a steroid to start with, to give you a rapid response. So here could be one option where you could start with a steroid, and then, so this was shown by the Bivodex study also, which showed that the Ozurdex had a much rapid decrease in CRT. The second one is presence of hard exudates. This probably works very well for me in the clinic. The moment I see this kind of a fundus picture, mentally I'm prepared to see that this could be resistant to anti-VEGF. So this is what is seen in the OCT also, subsequent serial injections, and we don't see too much of response. Type of edema, the diffuse, the cystic, and the neurosensory detachment. We know the neurosensory detachment has more inflammatory component to it, and this could be one of the types of edema which could respond better to systemic steroids, to intravitreal steroids. In fact, there's a paper which they have discussed that presence and absence of SND could actually be two different diseases altogether, where the presence of SND would mean that there could be an associated damage to ELM, or the external limited membrane, which allows this kind of extensive blood retinal barrier causing the CND to happen. In the RISE and RIDE study, they had anti-VEGF also showing a good response in patients with SND. But another study quoted that the response to SND in patients with SND, 86% could respond better to steroid, vis-a-vis 50% to anti-VEGF. Another, we had a lot of discussion on hyperreflective dots, and we have seen that could be the size can matter, the number can matter, the location can matter. So I'm not going to details of it, other than if they are closer to the ELZ, you would probably think more in terms of an aggressive treatment. And there are studies which have shown that dexamethasone could be a better alternative. Intraretinal cysts, again, we had this discussion. So I think not only the size, the presence of optical density ratio, as Dr. Mahesh wanted to discuss, and Dr. Avinash also responded to that. For me, I think the important thing is the presence of these cysts, and if they are so big that they are pressing upon the photoreceptors and causing an ELZ destruction, I would rather go in for a quick responding drug, which is the DEXA, rather than an anti-VEGF, so that I could maintain the foveal contour quickly. Choroidal biomarkers, we had a very good talk in the beginning of the session by Dr. Munna, who did mention that choroid is the important thing now. And again, in patients with SND, we have one common factor which did come ahead is that the choroidal thickness is generally more, which probably may be a VEGF-driven process, which drives the choroidal thickness as well. So a thicker choroid could respond better to a steroid vis-a-vis a thinner choroid. Same thing probably for the CVI as well, which will show you the luminal area and not only the stroma as well as the luminal area as is shown by a complete choroidal thickness. One interesting biomarker which has not been discussed so far is the fundus autofluorescence. So most of the cases, which I think mostly the cystoid kind of macular edema, shows increased fundus autofluorescence. And there was a study which showed that patients with increased autofluorescence, increased number of hyperreflective foci, and SND, all are probably the inflammatory biomarkers, and they do respond better to steroid injection. OCTA, just few things, more number of microorganisms in the DCP, lower vascular flow density, and a larger FAZ. Why the DCP? Because in majority, the artery and the vein lie in the superficial plexus and the capillaries in the deep plexus, and we know that the capillaries are the ones which are only surrounded by pericytes, and so the outpouching happens more often. So the DCP is the area to look for. This is something which I've seen in my experience as well, that whenever I have a cyst which is seen, usually the hyperreflective foci within the cyst corresponds to probably a microaneurysm, which you could pick up on an OCTA, and these are the ones which could respond better to a steroid as well. Larger FAZ would mean more resistant disease, and this is now beautifully picked up on OCTA. And it could also, any disruption on the DCP of the foveal vascular area will also cause a more resistant diabetic edema. So just for a switch, probably the only thing which you would like to see is define the response, whether it is, protocol I has given some definitions of this response. Only one thing that I would like to highlight, that this is what we all want to see. This is a good responder. And this has been picked up that more than 15% reduction in CRT after a single injection could be defined as a good responder, so you need not go up to 3 injections. But the general consensus is that by 12-week time, with a minimum of 3 anti-VEGF injection, if there is not a reasonable response to an anti-VEGF, you could consider a switch to steroids. Just 1 or 2 real-world scenarios. If we had the discussion on drill and large cysts, and disruption of EL. So in these kind of cases, you would probably want to shift over to a steroid first, so that if the visual acuity is not good, at least the patient has the minimum number of injections. This one particular patient, there's a mixed scenario. You see an SND as well as cystic spaces. So the intravitreal injection has reduced the SND, but the cystic space remains. So is this a responder or a non-responder? Another example, SND before injection, but the SND has come down, the cystic spaces have increased. So is this a responder or is it a non-responder? Real world scenario, no response after bevacizumab, after steroid a good response, but again the change happens with pan-retinal photocoagulation, and after cataract surgery we are back to square one. So it is a dynamic multifactorial problem. One single biomarker or imaging marker may not give us all the answers. We need to look at the whole patient. Thank you.